Conventional practice uses psychiatric diagnosis to locate problems within the child. The child is identified as having ADHD or being bipolar, disorders which need to be treated, preferably by medication. In this module, we deconstruct psychiatric diagnosis and examine what are we really medicating. We also offer an alternative framework for understanding the rationale for using medication based on psychoactive drug effects rather than their presumed corrective effects on a disorder within the child. Finally, we discuss good psychosocial interventions that improve well-being for even the most troubled children while causing little to no harm. Our aim as professionals is to provide the best outcomes possible for our clients. We believe that this requires fundamental retooling of our language, how we talk and describe the problems of children, of our own actual time and work with the children, and of the system of care itself.
Diagnosis of mental illness is considered scientific by many. People sometimes adopt a diagnosis as their identity. For example, I'm bipolar or I have ADHD. Millions of children carry these diagnoses. And in light of the existing data, how should we be thinking about diagnosis?
Well, a couple of things. First of all, different clinicians give the same clients different diagnoses, and most clinicians are familiar with this issue. If you review a client's chart, you will often find that over time, their diagnoses have shifted. But this brings up an important issue. If we don't have data showing that children can be accurately diagnosed with bipolar, then how can we justify the use of antipsychotics or mood stabilizers among children that carry that diagnosis?
I believe that we need to go beyond that. We should be moving away from understanding behavioral problems, behavioral difficulties in terms of diagnosis. Instead, we need to ask, what is this child's problem in behavioral terms? I don't believe we're medicating mental disorders. We're medicating negative behaviors, behaviors deemed undesirable, that represent understandable reactions to pretty bad life experiences. The DSM doesn't accurately capture the problems of children in child welfare. It makes you think you need to medicate an entity called a mental disorder. But the problems are caused by life and life experiences. I understand that the typical agency assessment and the payment systems currently require DSM and ICD diagnosis. And I understand how this contributes to maintaining the status quo of medication as a preferred response to children's distress.
Given that psychiatric diagnosis, as flawed as it is essentially mandatory in many practice settings, practitioners can at least adopt a harm reduction approach. Psychosocial professionals can avoid adopting the language of diagnosis as the problem to be treated in favor of opening up conversation to what the multiple and varied problems really are. In the next section, we look at how, in each of 8 DSM diagnoses, kids' underlying emotions of sadness, frustration, and hostility seem to play out across all diagnostic criteria.
When you diagnose a medicated child, what message do you think that child receives? I mean, I start to think, I'm broken, I'm diseased, but what are the social and other impacts, do you think, of doing so that we might not often think about? We might think we're helping the child by medicating them. But what are the things that happen socially when we do that?
The first effect I think about is really how it influences the social worker or the practitioner. So let's look at that relationship right away. And let me put this out for reflection. I know when I was trained as a social worker a number of years ago, that I was trained to work with the problem as it manifested itself. In other words, I had to work with the symptoms. I was trained to work with the anger, to de-escalate. I was trained to listen. I was trained to hold the shoulder. I was trained to work with a person in front of me and try to deal with whatever that person was expressing at that moment. That was the work I was trained to do, to be with them while they were experiencing this, to deflect some things, to validate others, to keep them safe. Myself, I had to do this. And I wonder to what extent people are trained to do this, or rather, to what extent they're trained to refer and to send to someone else to deal with it, so that we're spending less time with the child. And that, to me, is one of the effects of referring them for medication. We're, number one, giving a message that I can't handle this myself. I'm not trained to do this. This is bigger than what I can handle. And maybe it gives the child the message that this is something you're feeling that's too big for anyone to handle, and so we now need to turn to an object that's sort of actually more powerful than all of us, and it might solve the problem or help us to be dealing with each other. And so I'm concerned about what possible message that may be giving to a child. I don't think it's really a positive message about the power of human relationships.
If there's clear data showing that DSM diagnosis is not valid, then how do we understand the use of medications? Here's an analogy. As a socially shy person, if I drink a glass of wine before I go out, I feel more relaxed and more able to interact with others. This is a desirable effect, though in no way do I understand my use of alcohol as fixing a biological problem that causes my shyness. There are many reasons I'm shy, not a simple biological cause. The alcohol offers a psychoactive effect that I find helpful for modifying a specific behavior. This is how we can understand the use of psychiatric medications. There is no biological abnormality being targeted and corrected. Medications produce effects that we either find helpful or unhelpful. That's what we're really doing when we give medications to children. A century of observation confirms today's accepted wisdom. This wisdom says that children need safe, secure environments to thrive in, and that maltreatment and trauma disrupt the basis for development. Despite the immense speculation on genetic and neurochemical causes of psychosis, the strongest risk factor known to date is child maltreatment. Trauma changes the brain. However, the brain also changes in response to educational and psychosocial intervention, illustrating the principle of neuroplasticity. Neuroplasticity refers to the ability of the brain to change its structure and function according to the different environments and stimuli. People often ask, what's the alternative to medication? The answer is everything else that could have a positive impact on the well-being of a child. Social workers and other psychosocial professionals have a unique professional perspective to contribute to this area of practice. It's psychosocial professionals who are committed to values of self-determination and empowerment, who look at systems levels thinking, who engage with a person in environment. And these are skills and perspectives that are so valuable to this area of practice, and we encourage practitioners to be working within their microclinical setting and all of the roles that are called for in that setting, and then also to be thinking about their macro practice and what it looks like in this area where you are embedded in a much larger landscape. What does your practice look like at the systems level, at larger systems, in advocating for policy and legislation that is going to effectively move practice forward in this area?
We need to shift as a system to the healing or rehabilitative possibilities of psychosocial interventions using relationships and problem solving. We offer several possibilities such as mentoring, peer support, teaching skills, exercise, and good sleep and diet. Individualized attention from a competent adult and spending time developing meaningful relationships are effective for producing positive outcomes. We think these things will go a long way to reduce the use of psychiatric drugs.
For some time, it has not been politically correct to think of parents as responsible for their children's troubles. The fact is, unfortunately, they often are. Not speaking about this issue sensitively and responsibly limits our efforts to help children and parents. Several parent training and effectiveness programs exist. Autism is one of the most serious conditions described in the DSM. It is also considered one of the more biological conditions. The most effective intervention accepted to date for autism is nearly constant presence and engagement with the child. If this is the core principle for a serious condition like autism, then we believe that principle should be applied widely. There are hundreds of psychotherapies. We list a few of the more popular ones in child welfare settings. We often hear that combination treatment is the best, that combining medications with psychotherapy is the most effective option for treating children with behavioral problems. Commonsensically, 2 treatments would seem better than 1. But is the issue more complicated than that?
Yes, I think the use of combination therapy could violate the first do no harm principle. Psychotropic drugs have adverse effects, and psychotherapy generally does not. If a child doesn't have an adequate trial of a psychosocial intervention before proceeding to medication, ideally several trials, one will never know how the child would have improved without the medication. And in these situations, significant improvement is often attributed to the medication. Remember that there are effective psychosocial interventions for very disturbing behaviors.
For multiple reasons, the commonly accepted guideline of combination treatment is more complicated than often thought. First of all, children are sometimes said to be receiving combination treatment because they are started on medications and therapy. Any advantage for combination treatment presumes that the child is actually receiving both of these interventions. But we have heard of situations where a child is started on medications while in therapy, but over time, the therapy appointments wane, but the prescriptions remain. Such children are actually receiving meds-only treatment.
Also, in the famous treatment for adolescent depression study, combination treatment did result in quicker improvements than CBT alone. But by the time 18 months had passed, roughly 80% of the kids were recovered from their depression, no matter what treatment they had been assigned to.
Don't underestimate the impact of your positive attitude, enthusiasm, and empathy. Don't underestimate the healing potential of human relationships. The therapeutic modality you are using matters less than your interpersonal skills, values, and commitment to your client.
We have repeatedly stated that psychotropic medications should be used as an intervention of last resort with children. And in this course, we've given you many good reasons for why we would make such a recommendation. Yet in practice, this is seemingly often not how it works. A committed social worker or child welfare professional who actually advocates for their client to see that this is the case could do much good.